Good afternoon. My name is Kevin Biese. I am one of the co-hosts of the Geriatric Emergency Department, GEDC, West Health, Healthcare System Roundtable. And I'd just like to thank everyone on this line first and foremost for taking time out of your busy days to participate with us. These sessions are co-presented by GEDC and West Health. And our goal is to create a forum, a space where healthcare systems that are launching geriatric EDs across your system can share best practices, have open, free dialogue about what's working, what's not, and where West Health and GEDC can learn from your conversations to figure out what tools and opportunities we need to develop to help get the right resources in your hands to further disseminate GEDs. None of us would be on the line today if we didn't think that Geriatric Emergency Department had something to offer our healthcare systems and, more importantly, our patients. That there's a ways to improve the clinical experience of older adults that need emergency care, and that can be done in ways that improve the value of that care in both clinical care and the cost downstream. We can have really a true win for the patient and for the healthcare system if we do this better. It's been really exciting over the last few years of Geriatric Emergency Department development, which has been an incredibly collaborative effort across lots of institutions, including the GEDC, West Health, and many others, to see how this has evolved from individual practitioners saying, I will make my ED better for older adults, to healthcare systems saying, we will make our entire system better for older adults. And for obvious reasons, those of us who are in the business of saying, gosh, can we continue to grow the GED model? Does it work better? Are very interested in encouraging the system-wide spread of GEDs. But we've also come to realize that there are different challenges. It's one thing to make one ED a geriatric ED. It's another thing to make a whole system or many of your emergency departments across the system geriatric EDs. How do you track metrics? How do you scale care interventions? How do you deal with the fact that there's going to be different levels of engagement with different staff? How do you deal with contract ER groups as opposed to ones that you own yourself or hire yourself? All of this are things that you guys are living and breathing every day. So our goal is to get this group together quarterly, have high yield, impactful discussions about practical opportunities and challenges to improve healthcare system-wide dissemination. And for GEDC and West Health to listen in, to learn how we can take what you're teaching each other and disseminate it. To be very pragmatic, each session will be sort of catered by GEDC and West Health and hosted by one of the healthcare systems. And this time, Advocate Aurora has generously offered to do the hosting. Hosting means sharing briefly something that you're working on. Not that's all fixed and tidy, it's not a research presentation, but something you're working on and developing in hopes of spurring conversation to get best tips that help you. And clearly your experience will impact others. So you guide the conversation. Next quarter, we're looking for volunteers, but we'll ask for the next group to host that session and go on forward. So our ask is that everyone, if you're able to, can host some of these sessions moving forward. So I think that gets us started. Today, we've got a great GEDC team here with us, and I'm going to turn it over to Adriane to talk a little bit about West Health's role in our healthcare system roundtable and also more generally. So really excited. Thank you again. Hold on, we're gonna dive right in and see what we can learn from each other about best practices in healthcare system-wide dissemination of GEDs. Adriane, over to you.
Thanks, Kevin. So I'm Adriane Lesser. I lead our GED research efforts here at West Health. I know many of you have partnered with West before, but for those of you who are just getting to know us, West Health is a family of nonprofits dedicated to lowering healthcare costs to enable seniors to age in place. And we have the West Health Institute and Foundation in La Jolla, as well as the West Health Policy Center in Washington, D.C. that works towards those objectives. So my team and I are very excited to have all of you here today as we kick off the GED Healthcare Roundtable series. In addition to myself, our Chief Medical Officer, Zia Aga, and EVP John Zifferblatt will be co-traveling with us on the series, and Program Manager Misty Benson and our Program Coordinator Emily Adams will as well. Next slide, please. So we're thrilled to be bringing together all of you today, the key health systems, as Kevin said, driving innovation, leading the way in geriatric emergency medicine. In just a minute, you'll have the opportunity to introduce yourselves. But first, I just wanted to set the stage by touching on what I think are the common goals that we all have here today. So, we hope that this will be an opportunity for all of you to make connections with each other, to collaborate with each other, and to disseminate, best practices amongst yourselves, but also to explore opportunities to share your learnings with other health systems that might be interested in establishing geriatric emergency departments. And then specifically today's section, we're hoping to determine the next steps, the topics that are of most interest to you all to help set the stage for future roundtable sessions. So I want to pause here for just a minute to give John Zifferblatt a chance to introduce himself and say a few words.
Hi, Adriane. Thanks. Hi, all. Really appreciate this. I just wanted to echo Kevin and Adriane's comments, how delighted all of us are to see this come together. When we were, starting and as we've been continued to work on GEDs, I remember thinking one wish I had was that we could see GEDs be adopted at a system-wide level, health system by health system, and that those health systems could then help the GEDC and others guide further adoption. And so I feel like two wishes have been granted to me. Canonically, then there's one remaining to me, which I'll probably save until after the election, but really could not be more delighted with this. And I think in addition to what Kevin talked about and what you will be talking about in terms of sharing best practices, challenges, opportunities, I do think that there's probably some emergent properties that begin to manifest themselves when you have GEDs at a system level. And I think it would be very interesting to begin to understand what those are and what those unique opportunities are when you have an entire system or parts of an entire system which have GEDs, whether it's do you divide, this one's falls, this one's going to focus on meds, do you do all of it together, do they feed each other? All of these emergent properties that we don't know yet, but we'll be finding out. So very excited, I'm so thankful and really keen to see this work go forward.
Thanks, John. So let's dive in. Just a reminder that, the purpose here is all for everyone to share your experience. So please don't be shy, jump in with any feedback you have, either speak up or feel free to use the Zoom chat function so that we all can get the most out of this roundtable. And now I'd like to just pass it off to each of the health systems to allow you all to give just a brief high-level introduction to the GEDs in your health system and what you're hoping to get out of this roundtable. We'll start with our site that's facilitating today's session, Aurora.
So I'm Mike Malone, and thank you, Adriane and John. We're happy to send good wishes to you in California. So from our programs, we work for Advocate Aurora Health, and it's a large not-for-profit health system, mostly in the Chicagoland area. And now as well, we're combined together with this advocate program called Advocate Aurora, so into Wisconsin as well. So we serve communities across eastern Wisconsin and into the Chicago metro area. Our teams are mostly based in what's called senior services programs. So I'm going to go from bottom up on this list with our Chris Rubach, who's with us today, who's program manager, who guides the dissemination of the programs as well. Susie Ryer, a physical therapist, who likewise guides the dissemination of this program as well, our falls prevention project, along with Ann Gallo, who's pushed and led us from the beginning of many of these projects. Patty Pagel is the director of senior services. Erin Malsh is the program manager for this large project, and you'll hear this about this program for Geriatric Emergency Department. And I'm a geriatrician who's been had an interest in the care of vulnerable older adults over the last several decades. So we're interested in a number of issues having to do with implementing a best practice as senior services within this complex health system. And, you know, the unique part is that we're not emergency room providers. So that's kind of like, you'll hear that tone from the beginning. And then we'll tell you the story of how we've, in that context, tried to better, to improve, go from where we are towards better. And you'll hear this story shortly.
Thank you so much, Mike. Appreciate it. Northwell, can you introduce yourselves?
Sure. So can you hear me, hopefully?
Yes.
Fabulous. Okay. So I think Dr. Amato is trying to connect. So I'll do my best to do the introductions of our health system. So you may or may not have heard of us now that COVID has made us nationally known, unfortunately, but Northwell Health is a health system in New York State that serves about 218,000 older adults annually. We have 17 emergency rooms across the state that are involved in our Geriatric Emergency Department process. We do have 18 emergency rooms. The 18th is actually a pediatric, so we've eliminated that from our discussion here.
Hey, Tara, it's Teresa Amato. I am on.
Hey, welcome. Okay, so you can speak a little bit more to the departments that we serve.
Sure, yeah. So we, like Tara was saying, great introduction is we do have 18 emergency departments, but one of them is a purely pediatric emergency department. And our other 17 include 3 tertiary sites and some community sites as well. And we were very excited last year that we were able to actually get a level 3 accreditation for geriatrics for all of our adult emergency departments. And Tara, you want to talk a little bit about the number of patients we see?
Yeah, so I would say we have about 218,000 older adults served annually, which is a large number across the tri-state area. And the team members are included, and I know, you know, Aurora is mostly geriatricians and physical therapists. We're actually all majority of emergency room doctors. Dr. Amato is the director of our geriatric emergency department for across the service line. And then there's in each site a physician and a nurse lead at each of the sites, the 17 sites. And I'm work as co-management of this team just to be a advisor for geriatrics in the emergency room. And we're really interested in learning about strategies to improve community partnerships with our EDs across our large, diverse demographic area. We serve a very diverse area of New York State where it's very, you know, rural to urban. And so how that affects the patients that we're taking care of. And Teresa, I don't know if you want to just talk about the rest.
Yep. And so what we'd like to, some of our goals of participating in the collaborative, this group here is we would like to learn a little bit more about, you know, how to deal with the diversity in our elderly patients, and specifically language is a big issue for us. And also to share our journey of what it meant to try to get all of the EDs up and running as a geriatric accreditation and what that process was like for us. So we'd like to share with other organizations and also hear their journey. And thank you for having us. We really appreciate being involved.
We're really excited.
Thanks so much to both of you and to your entire system for your leadership. Next. That's awesome. Couldn't be more grateful. Dartmouth, can you introduce yourself?
Am I the only one on from Dartmouth at this time?
Jen's here, Kathy.
Oh, good.
Jennifer. Yeah.
Do you want me to go ahead and kick us off?
Yes, please.
Okay, sure. So sorry. I think we were expecting a couple other members of leadership from our project team, but the ED here has been a little crazy today, and so I'm more than happy to jump in and pinch hit a bit. My name is Jennifer Raymond, and I'm a project manager supporting the work of hopefully becoming accredited as a level 1 geriatric emergency department here at Dartmouth Hitchcock Medical Center. We are currently a single emergency department serving the Twin States of New Hampshire and Vermont. One of the goals of our work is to also spread our services virtually through our mature telehealth program in support of 4 rural critical access hospitals, which will then help support in becoming level 2 accredited geriatric emergency department. So right now we're just the 1, but we'll be expanding to provide services to 4 additional. The older adults served in RED annually, there you can see it is 9,800. And in addition to myself, some of the key team members who have really been moving this work forward are Dr. Susie Varga, who's the medical director of our geriatric ED, Hillary Hawkins, who's the program nurse manager, and Kathy Wilichko, who's on the call with me today. Dr. Daniel Stadler should also be listed here, as he's the geriatrician who's working on this project, and he's the director of geriatrics here at Dartmouth Hitchcock. I apologize for not having my video on, but I'll tell you that I'm working in a shared workspace in the middle of the ED, and so there's a bit of chaos going on at times behind me. However, I think we are also very delighted to be a part of this discussion and to be learning from people, particularly across the country, who have more mature programs than us. Happy to share that COVID certainly has impacted and delayed to some degree some of the progress we had momentum building over the wintertime, but we're slowly overcoming that. Particularly what has us fired up here at DH is focused on goals of care and what matters most to patients. And so we're very, very curious to hear from other organizations if there's any work going on in this space in which you're identifying what matters most to patients. And specifically, if there are any emerging measures with respect to concordance of care. So that is based on a patient's goals of care, values, and wishes, is the care that's delivered during an ED visit concordant with what they actually want and need. Kathy, I don't know if you want to add anything to that.
Nope, you always sum it really well, Jen.
Okay, thanks.
Thank you guys so much. Really exciting, and certainly not as large a healthcare system as some of the others, but innovative use of telehealth to get these services in rural settings, and perhaps something that all of us can learn from. Thank you guys so much. And then Vaishal or other, do you want to talk about the University of California system-wide program?
Yeah, absolutely. Can you guys hear me okay?
Yes.
Great. Okay. So my name is Vaishal Tolia. I'm an emergency physician and hospitalist at UCSD. And our initiative is really to try to bring geriatric ED to all 5 of the medical centers, UCLA, Irvine, Davis, and San Francisco. And really, kind of creating a statewide network of geriatric care, both locally here in San Diego and throughout the state of California, with each of the UC medical centers really being a hub for geriatric care in the region, and hopefully using that model to spread geriatric care within the area. So I think from my perspective, understanding how these individual systems and us as the leader in California can really support the other systems and grow both at an academic medical center and regionally to our community partners. And then looking long-term at how we can spread this ROI argument for long-term sustainability. So excited to hear about other people's experience and appreciate the opportunity to work with everybody.
Thank you so much, Vaishal, and really exciting work across California. Excited to learn more about it. And next up, can we go to the next? Who would like to take us from the VA? Luna, do I see you on? Would you like to share what's happening in the VA?
Sure. I'm Luna Ragsdale. I am an emergency medicine physician with the VA, and we currently have 5 emergency departments that are accredited. 2 are currently, 2 other VAs have applied and are undergoing review, and then we expect to have 13 more apply by the end of September. For those 20 sites that will have applied, I've shown the states that they're in. Those serve over 200,000 older adults last year. And then the VHA, the whole hospital administration, serves over 1 million in their EDs every year. And that's 110 EDs in our system. Our team members are Erica Gruber, who is super enthusiastic and is sad she can't join us, but she's a nurse practitioner. And really the person who started all this and drove all this is Jill Huded. I think she's on, but maybe muted to save us from her children. But she has been working with Kevin and West Health and John A. Hartford and EULA to bring this all here. So EULA is also part of our co-lead for this group. So what we're hoping to do in the next few years is to bring on more EDs. Again, we have 110, and so we would like to increase that number. But I think to do so, we need to create some sort of national dashboard, build a toolkit to make it easier for sites who may want to level up, and then also provide some sort of standardization, but we also want these sites to have some individual autonomy and creativity. And so I like to figure out how other systems are doing this with their multi-sites.
Awesome. Thank you so much, Luna. Really exciting. And given the percentage of veterans that are older adults, it's really phenomenal to think about the work that you're doing. And last but far from least, Mayo, can you share a little bit with us about your work with geriatric EDs?
Hi, my name is Jessica Stanich. I'm an emergency medicine consultant at Mayo in Rochester. And we are currently partnering mostly with our Eau Claire site, and Alex, I think, is on. And in the process of applying and creating our application for level 1 in Rochester. Our health system consists of 20 emergency departments. There are essentially 4 major hubs, with Rochester being the largest, seeing around 76,000 patients a year, with somewhere around 22 to 30,000 older adults. The other 3 hubs, which are similar to Eau Claire, see around 10,000. And then we have several other sites that make up more of our critical access sites, some very small, some a little bit larger. So fairly large system. Our team members are Susan Bauer, who's our Rochester nurse champion, and has been involved with the changes we've already started in Rochester from the beginning. And Alex is leading the Eau Claire group, and in truth has done a ton of work towards their application, and I think are ready to apply, and I'll let Alex speak to that. And then Fernanda Bololio and I are both working together in Rochester. It's humbling to hear everybody else speak about their process, and one of the parts we're at, I think, now in how do we create some autonomy, but then also have some consistency amongst the groups, knowing that our different systems have different volumes and different challenges, and a different population. And so trying to work through which protocols and policies are right to keep sort of standard and universal, and which things we should probably leave more tailored to the site, is something I think we're going to have to answer soon in our system. And we have some discussions coming just in the next week with leadership on how to actually start truly moving forward. So we're excited, and excited to hear about everybody else's experience. I think this is going to be a really valuable discussion. I don't know, Alex, if you want to speak for a moment.
Okay, I'm unmuted. Hi, thanks, Dr. Stanich. So I guess my biggest interest is, we actually met today with some of our the hospitals outside of Rochester, the smaller hospitals, have a a core group of leaders that get together to talk about shared projects. And I described our work in Eau Claire and with Jessica and Fernanda in Rochester. One of the things I'm curious to hear from other sites is we have, as we do some of our quality projects to prepare for having surveyors come in and evaluate our program, Mayo Clinic's very good at standardizing, but that can also mean if you're trying to standardize across a EMR platform like Epic, that is what we use, there are issues with having a set screening tool. Mayo's, I've heard it described as kind of like the Titanic. It takes a long time to turn the ship, but once it gets turned, it does a very, very good job of moving in the right direction. The problem is, and I'm actually a trauma surveyor as well in Wisconsin, and we expect trauma programs, and I presume the surveyors on this call would say the same about geriatric EDs, that we expect them to, while they can certainly utilize system resources, they really should know their own population, be able to nimbly move to affect the outcomes within their own emergency department. If they're just using power decks from the hub academic site and then saying they do the work, but actually aren't doing the work at their smaller sites, that's probably not the best thing for their patient population. And so as a trauma surveyor, I've seen, I go to a hospital survey up near Lake Superior in Wisconsin, and they have a snowmobile race every year across the the lake, and sometimes it doesn't freeze and people fall through, and so they'll have a safety project. Similarly, if it's a hospital down by Milwaukee, they're worried about other issues with their trauma program, and I'm presuming it'll be the same with our geriatric programs across 20 upper Midwest EDs. So how do we use those different things to utilize shared dashboards, utilize shared screening tools across our ERs in Epic, our EMR survey? So I'm curious of how other people have dealt with that while still trying to have a standardized approach.
Awesome. If I stayed within the frame, you would see me bouncing up and down right now with excitement, given the magnitude of potential impact for older adults across our country that's represented on this meeting today. Incredibly exciting. Last thing I'm going to say before I turn it over to Advocate Aurora is I neglected to point out that Eula Wong and I are the co-PIs of the Geriatric Emergency Department Collaborative. Eula's on this, and we are here to help you in any way we can. And then Laura and Connor and Lorraine sort of run the hub of the GEDC, and they too are here to help you in any way that we possibly can during this journey in partnership with the West Health team. I'm going to turn it over to our colleagues from Advocate Aurora who are facilitating or hosting this first session. Ask you the impossible ask of trying to do the presentation in about 15 minutes if possible, so that there's a little bit of time of discussion, and we've gotten a whole lot more topics to cover in our upcoming meetings already. So thank you again. Really excited to get rolling. Advocate Aurora, you're on.
Excellent. So hello, my name is Aaron Mulch. If you can advance to the next slide, please. I'm going to go, I have quite a few slides here, but we'll have these slides available for everyone else, and you can go back to them. So I'm not going to hit too much of the details. Next slide, please. Lorraine? Oh, okay. We'll get just going here.
Connor, is it not working? I can.
Yeah, there's some technical difficulty, I think, on Lorraine's end. I'm trying to share now.
I can, if you want. I'm fine sharing my screen or my slides.
Well, why don't you do that, Aaron, since you're driving?
Okay. There we go. People can see my screen?
Yes.
Okay. And still seeing it?
Yes.
Yep.
Okay, excellent. Okay, so I'm going to let's just get right through these here. So very, very quickly, pretty large system, 26 adult or 26 EDs, 2 of them are pediatric. We actually have a 27th because it's behavioral health. But some of the complexity going from very small rural sites to very large tertiary sites. We have at least 7 medical groups that I know of across our 2 states. And what you see with some of those volumes is really a combination of both of our sites. And last year, when you had 10 of our sites up with the program, we've been able to screen up to 42,000 older adults. So we're very excited about that.
Aaron, it's Mike. We
Yes.
still see the Northwell Health slide on your screen.
Oh, really?
Which is fine, but you know, you're welcome to move along. There we go. Oh.
Okay.
Now we see everybody, kind of the Brady Bunch type screen.
Okay.
Now we see.
Perfect.
There we go.
Perfect.
Okay.
Thank you, Aaron.
So I apologize about that. But looking at our approach, so we're very much looking at older adults that come into our emergency departments, but we're discharging back. Very much focused on as much evidence-based, having this interprofessional, and then working with a lot of our system partnerships with ACOs, population health, and others. And we're really trying to focus on having this as something that's scalable. It's not just at a single site, but we're try to have as much standardization. So that question about how much do we tailor per each site versus how much do we have as a universal is near and dear to my heart. We very much try to make sure our sites are having leadership and ownership, and us as senior services being able to support them. And oops, there we go. It's finally going through now. So some of the unique characteristics of our site. We started this way late in 2014, and this is really very much a grassroots effort. There was no GEDC at the time. We just received the guidelines and was able to take something that we thought was going to be a 6-month pilot at 3 of our sites, and it's very much grown over the years. We've fundamentally used the ISAR as a foundation. This is kind of our level 3 baseline, and then building such things as falls, mobility, additional programs off that infrastructure. Some of the things that are unique is that a universal model, if you would say. So in none of our sites do we have separate beds or a separate workflow. That said, we only have level 3s right now. This year we'll have one site at least at level 2. But I anticipate if we're going with a few of our sites at level 1, we might have to rethink that just because of the actual burden of doing that level 1 screening and so on and so forth. Another unique aspect is Dr. Malone, Patty, Chris, Susie, and myself, we don't work in the ED. We do not report to the ED. We're a system geriatrics. So it's unique. There's definitely some pros and cons, but we really look as us as facilitators. While we might not be the skeletal system or the muscles, but we sure might be the ligaments and all the other connective tissue trying to support our teams. One of the other things we can talk about in maybe later is we definitely use our twice annual booster sessions where we bring all our teams together to make sure that we're progressing as a system. This is just a real quick timeline. The basic, I'm just going to skip over that for right now. You can look at that later. Is really we're trying to look at this as having this as a system approach. Level 3 should be a standard of care. Then from there, we anticipate, depending on the site, the population that they serve, 40 to 50% of our sites being level 2. And then over our large geographic area, are there 2 or 3 of those large tertiary centers that will be level 1. That said, we're trying to make this standardized. So it's not 24 programs at 24 sites, rather it's 1. We can get into some more detail with that. These are some of our bigger initiatives. We can focus on a little bit later, but I want to make sure that we have more time for conversation. Some of our successes, it's been great for our culture in our emergency departments, the teamwork. It's really been, many of our leaders have been on the nursing side, which might be unique when I've talked to some of our other sites, and we've had some, starting to have some very good outcomes. Challenges we have can be inconsistency from site to site. We would love to have better tracking and data. We're continuing to improve on that. And then obviously with this being a new field of medicine, having appropriate validated tools and an evidence base, that's really lacking. And I applaud the work of GEAR to make sure that we have that. Obviously, ED is a busy place with competing priorities, and we definitely do not have our resources consistent from our 9,000 annual volume ED very rural to, you know, our 100,000 ones in urban areas. So those are some of our big concerns, like lessons learned. When we worked with these multi-component, multi-discipline protocols, they've been a little bit slower than we've liked, but there's lots of ins and outs in trying to work with how do we create the correct process measures to make sure that we're moving forward. One of the great strategies with this is making sure we maintain momentum. So taking the approach of using what we have in the EHR with policy and augmenting and aligning. Making sure that we work with our stakeholders and looking at our system metrics. I put robust is because we wanted to have it robust. We're definitely not there yet, and we're always wanting to continually to improve. Some of the things potentially we might, during the discussion, highlight some of our approaches, but very quickly, Chris Rubach has been a great member of our team where we've been able to take our data, and this is what's at every site. So you can see we have this is using BI or Power BI, which is a Microsoft product. And this is embedded within our SharePoint where all sites can access this. And so it's a nice slicer and dicer where we can go from site to site, click on that. You can look at by month. We have our standard sets, which is kind of like the lowest common denominator of our metrics. We take a lot of feedback from our sites about what we have and how we present it. Maybe we'll definitely go into a little bit more detail. The other one is, so this is our same dashboard, but you can toggle between our GERI metrics and our falls. And so we have a different set of information. And so all 15 of our sites that are with this can access this, go in here at any time. So we have this as self-serve. With that, we just have, this is about half of our sites, just showing the variability from 9,000 beds or 9,000 visits a year to 80,000, from 9% older adults as a percentage coming in of visits to up to 42%. So lots of variability that we have to accommodate for. And with that, I want to switch over to discuss questions. Kevin, is this something that you wanted to lead, or how do we want to approach this?
Aaron, that was amazing. And I bet you there's going to be a lot of questions and comments because there's such a wealth of information that you just went over. One little comment is right now there's closed captions on the screen. I don't know if that should continue or not, but that's fine if it does. The first question was that we thought we might ask from this excellent presentation by Advocate Aurora was to the other 5 sites, how do you all organize your data? Have you gone down the path that Advocate Aurora has here of sort of a central data hub? And if so, what programs have helped you do that? And how do you have a standardized EHR across all sites? And how do you manage variability? But any thoughts you have on your experience trying to get data from multiple hospitals and coordinate them for your GED projects?
This is Luna Ragsdale. I mean, the VA has the same EMR in all their sites. And so we're trying to see if we can pattern ourselves after our first level 1 Geri ED in Cleveland. And ideally, we haven't created a system yet, but I mean, there are ways to create a dashboard with the same health factors is what we use them as, is what we call them. But basically, since we have the same EMR, we can search all these documents for these factors and potentially create a national dashboard. Now, we already have a national dashboard for the emergency department, and then there's a geriatrics age report for that as well. But that really just gives you the number of people, you know, age 65 and over who've been seen, who have been admitted. And then it also breaks down into, you know, the other age groups, the 75 and over and 85 and over. So I think the tool is there. We just need to know how to coordinate it.
So I'd love to speak a little bit more about this too. So I think what Luna's referring to, so the VA uses the oldest electronic medical record in like the country. It's called CPRS, Computerized Patient Reporting Services. What the centralized process is right now is they have a centralized data repository, but each VA within having this electronic medical record, they need to program locally, you know, how the data appears. And so what we're hoping to do, at least with that version of our EMR, is if something's built, for example, at Cleveland, they can take what they built and then share it with the other sites. And now the other sites need to have their programmers try to mimic it. And then it gets uploaded. So it's a, I think, you know, for many of the other hospitals and systems here, many probably use Epic. And I think that opportunity to have maybe some shared templates, it may undergo the same process. Like you would think, oh, we all have Epic, we can all use like the same thing, but locally things are programmed a little bit differently. And I think that opportunity to try to share and standardize is probably what many of us are driving for. And so I think, you know, Luna's highlighting some potential opportunities and strengths, because if we're sharing it within our own platforms, but we still need to do that programming locally, why can't we just share some of these commonalities even across different platforms? So I think some really good opportunities to standardize, but then, you know, in terms of the local implementation, that you're going to probably need to find your own people at your own hospitals to then help facilitate sort of making sure that that data is collected in a way that it can now all be standardized.
It's Mike. I would say that we learned to tinker with these tools. We went from, as I was telling Aaron, so I'm sitting at a large countertop where we did chart reviews and put out chart reviews of different, you know, each with pieces of paper, kind of like from patients who had fallen, to a model where, thanks to Aaron, we had a BI launch pad. So kind of pull out information from Epic and give reports on a weekly and monthly basis. That was automated. And then with Chris Rubach and others, we're able to now go to a whole nother level of sophistication where so that each team can look at their, or each site can look at their outcomes reports like each week or each month. So again, different folks have brought different skill sets, and it's just like moved us from I'll just say from the lowest level Toyota that you could get all the way up to a Ferrari in this.
Ferraris are very practical in Wisconsin.
Bad example. Sorry.
That's awesome. Thank you. Are there sites that aren't all on the same EHR or have found other sort of third-party tools that were helpful for sharing data? Just to kind of open it up to Northwell or Mayo or others, are there any sort of additional challenges of not being in the same EHR and any creative problem solving around that?
Well, Kevin, this is Jen Raymond from Dartmouth, and I'd just like to say that if there's one aha moment I've had thus far, it's definitely seeing Aaron model that dashboard that they have built in SharePoint, because as you know, while we're striving to become accredited ourselves, and we happen to be on Epic, and we intend to select at least one system member to be a partner spoke site who is also on the same EMR. The other 3 entities that we are porting right now are not on Epic, and so we have to be thinking creatively about how we work with their data analysts to take metrics and inputs and data from those sites and be able to create sort of a common dashboard that, as Aaron just demonstrated, we can toggle through, feeding that platform with inputs from potentially 3 different EMRs, and be able to evaluate and measure and track as time goes on. So Aaron, I'll be emailing you a little later about who my people can be in touch with on Advocate Aurora's end, because I think we'd be interested to know how you built it and be able to try to replicate something similar if there aren't other ideal solutions out there.
Yeah. Chris Rubach is really, we had ideas, but he made this manifest, which is absolutely amazing. And you know, with any of these data pieces, so we're happy to, I know we have short time today, but we're happy to do demos and our specific journey with that. One of the big things is, so this is years worth of effort where we're at right now. We started out with, especially in the beginning, doing just manual chart reviews, put it in our own Excel file. Then as we were able to refine our metrics, and it was always this delicate balancing act between process metrics versus patient outcomes. And we were definitely heavy on the process metrics, just so to, how do we give support back to our teams so they can have feedback on what they're doing or maybe not doing. So this is definitely, you don't flip a switch. This has definitely been a process.
Awesome. I know you've got some more questions that you organized for us here. We're kind of going into this. Any comments on how many folks have really started to get an automated system that compiles data from the different sites or pulls it together versus how much of it has to be manual? And I've heard the Advocate Aurora team already share that they started with a more manual approach. They are all on Epic, and yet they're using sort of a third party or a Microsoft product to kind of pull some of that together. Aaron, maybe just say a couple more words on why you picked that product and what it does for you outside of Epic, and then I'd open it up to others to talk about where they are on the manual to automation pathway.
Yeah, it definitely, with the manual, was very helpful because you can look at all different kinds of things, and you can really hone what are those essential pieces, and then get feedback from. This is one of the big things is these, you know, Aaron has some ideas and Dr. Malone has some ideas, but we get a ton of feedback from each site because they bring up things that I would never have thought of. And so I think finding the right mix of what those metrics are is essential. And then from there is when I know that we have sometimes very long waits between when we put in requests for build, like for a report. So we use Clarity reports out of Epic, and sometimes we've hit gold, and sometimes I've had to wait a year, which seems ridiculous. And so going into that, you know, knowing what you want to ask for and not everything, and then thinking about what's universal to each and every one of your sites, because some of the needs at our big urban inner city hospitals versus very small rural can be quite different. So that is probably one of the things. And then, so once we had those Clarity reports, you know, it's wonderful. You have to kick them out on these big Excel sheets, but we still found that we need to do grooming where we have to go through this. And this is what Chris has been able to take is and be able to present this. So using Power BI, we use this because it's a Microsoft Office product that our system supports or pays for, so we didn't have to bring in an extra money. And so we wanted to utilize the technology that was coming through the system. And that really gives us the ability to take kind of these raw data into something that's very actionable useful for our sites. So that was kind of our journey, in slow, painful journey at that. And then there's even some pieces I want to engage with, how people developed their metrics for specific protocols. That is always something I would always like to learn from others with that.
Awesome. I see in the chat that, thank you for that, Aaron. I see in the chat that Teresa from Amato, Dr. Amato from Northwell, uses Tableau. Can you just say a couple words about that? Because I'm thinking about the different systems hearing what each other is using for data compilation.
Yeah, so this is Chris Rubach from Advocate Aurora. Regarding Tableau, it's a very similar product to Microsoft Power BI. It's a data visualization product that's much more robust than Microsoft Excel. We went with Power BI, like Aaron said, because it's a free product. We have an enterprise level account for Office 365, and it's included in that. It's very comparable to Tableau. So if a system has Tableau, you can do very similar data modeling and data visualization, like we showed a few slides previous in the dashboard.
Awesome. And anybody from Northwell, Teresa, or other want to share a little bit more about your experience with Tableau or why you picked that?
I'm not sure if Teresa's able to speak. Honestly, to be frank, I'm the geriatrician, so I don't know. The Tableau is used by our EMR from the ER, and it's very useful. They can pull data in real time and able to sort of see across health systems in different places. So I think that it's been very useful to sort of ideally understand where the demographics are and what is needed and where to work on different issues. But I don't know why they picked Tableau, to be honest with you. So I'm sorry for that answer.
That's a great answer. Perfectly
No
clear.
idea. Maybe someone bought it. I have no idea.
Oh, thank you. Thanks for being a part of all of this. Thank you for what you're doing. It's an amazing number of EDs that you guys are working with. What next question did we have, just to kind of continue? We got a couple minutes left and we can go to the next slide.
Yeah, I thought this was an excellent question because, the whole reason for having these dashboards and is one, to give feedback and then to be able to demonstrate your outcomes. I'm kind of curious with other sites, how you use that, if it's from Tableau, or how you provide this information. Is it retrospective, monthly? Is it a minimum kind of data set? I just wanted to hear from other sites in regards to how they give this feedback and what's the vector for the information.
So I can answer that, actually. That's easy for me. So we actually have monthly meetings from each of the sites via our Teams, or I guess there's a Zoom sort of meeting, and we discuss data. We discuss topics about what is learning from the issues that we've had through our data feedback. So it's actually a really good forum to meet monthly and to have topics that we discuss, and then also to get feedback around data that we've encountered and how to go to the next level at each of our sites about how to keep metrics and how to figure out what is the important thing. I throw out to the team, though, we get a lot of data, but the question is, what is the data that we really want? And so I wonder what, if this is an opportunity for us to standardize the data across all of our emergency rooms, to say this is what's most important for a GED, and then individualize it for each of their local conversations. Because I think that's where we really are kind of struggling, is we get a lot of data, but what's the most important thing for our patient population?
Yeah,
from the UCSD side and the UC system, it's very similar. And I think, we're trying to figure that out in terms of what to do with the data. We meet monthly with the sites as we're trying to develop it, but internally we meet, every 2 weeks to every month pretty regularly and go over this data and give feedback on performance and outcomes and things like that. So, I think one of the challenges as we develop this on a larger scale is, not only standardizing the data and what comes in, but really figuring out how each site separately is handling the outcomes of those results in that data, because some of it has to be individualized to the region, to the location, and how much should we force all these systems to sort of adopt one single model. So, I think understanding the degree of flexibility is what, I think is a bit of a challenge for me. I mean, ultimately, what I'd like to see, which I think is a challenge nationally, is looking at what happens beyond the emergency department and, what is the impact of what we're actually doing, and how do we actually, gather that data post-ED and even beyond, to show that, collecting all this, doing all this, making all this effort is actually having a longer term impact. Like we think it is. It seems intuitive, I think, to everybody in this call, but, I think we just need data to support it. And that'll help the scalability too.
Awesome. Jessica, any comments on Mayo is like a QI machine?
Yeah, so that you're
how are you
speaking to my heart right now, because one of the projects I've been focused on are Susan and Fernanda has been delirium screening. And although, we're talking about in our discussion right now, large data sets, I'm comparing it to like the individual data that we're looking at just in delirium screening. And so there was hesitation in making delirium screening totally mandatory in our Rochester ED. And so we've essentially looked at many different things that are impacting whether people are being screened or not. And so I think when it comes to giving feedback, I think that we have to be thoughtful about like the specific thing we're looking at. If you look at just our delirium screening, what we've learned along the way is that, screening has been difficult in terms of nurses feeling, nursing completing the screening correctly. We've looked at what the driving forces around that were. We looked at how it impacted workflow and whether that was impacting them screening. We looked at how COVID definitely put a damper on things for us at the beginning, but then we realized that delirium's probably going up during COVID when we have masks and when we have no family at the bedside and we have patients locked in rooms with limited, contact with even providers. And so we found that our rates of delirium were actually going up during COVID. And so that pushed more better buy-in from nursing to do the screening. So I think that the harder part about giving feedback when you have lots of data is some of it has to be individual and more fine-tuned, I think, in order to really have impact and have change happen the way you want to. And some of that will be site-specific based on volumes, based on nursing experience, if it's screening you're looking at, just ISAR or delirium screening. And so I think our feedback just from delirium and looking at that data and looking at incidents and looking at completed screens and looking at what's happening in the department at those times as well, knowing COVID was happening, all of that has made our total number of patients screened increased, and the screening being completed correctly. All of that has been improving steadily over a slower than wanted time frame, but we've looked at small pieces of data throughout that's allowed us to have better buy-in, I think, and have the screening being conducted correctly.
Awesome. It makes me sad to report that it's the top of the hour, but I want to honor on this line everyone's incredibly busy schedule. I'm going to ask that the team will work together. We're going to send out an email with the chat, a link to the chat. We're going to create a folder on the GEDC website. We'll give you the link with resources for this roundtable, so there can be some resources. And in that email, we're also going to ask if anybody would like to help facilitate or host the next session, like Advocate Aurora's team did such an excellent job of today. Any topics that you'd like to hear about on future sessions, though we covered some of that already, and any suggestion of how to make this process better, because we're all learning together. Couldn't be more excited or more grateful. I turn it over to my colleagues at West Health or EULA to make any final comments, and then wish you all a wonderful day.
Final comments from me are just excellent session. Thank you, Aurora Advocate Health, for hosting the first one. I think you've set the bar quite high for all the other systems to, try to follow in your footsteps of like the great work that you're doing and inspiring actually all of our systems. I think this is a wonderful opportunity, not only for us to learn from our individual hospitals, but now as a system for us to continue to learn and really move forward the improvement of geriatric emergency care across the country.
Awesome. Thank you.
And West, from us, I think we just say we're also very thankful for everyone sharing their insights, and we're looking forward to future sessions and learning more.
Thank you so much. This is exactly the tone we're looking for. Look for some follow-up emails with additional information and resources. Meet again in another quarter. We can decide together whether that's the right cadence and how we can be of best service to each other. Thanks for this amazing start. Have a great day.
Thank you, everyone.
Thanks, everyone.
Thanks, everyone. Bye.
Care.